The observer should explain the procedure briefly to the patient. In particular, they should warn the patient of the minor discomfort caused by inflation and deflation of the cuff, and tell the patient that the measurement may be repeated several times. The patient should be in a warm environment. Tight or restrictive clothing should be removed from the arm. An appropriate sized cuff should be applied to the upper arm. The centre of the cuff bladder should be positioned over the artery. The cuff should fit firmly and be comfortably secured. The lower edge of the bladder should be 2 to 3 centimetres above the point of the maximum pulsation of the brachial artery. The British Hypertension Society recommends that the tubing should exit from the top of the cuff so that it does not interfere with the placing of the stethoscope in the antecubital fossa. The arm should be horizontal and supported at the level of the heart, because dependency of the arm below heart level leads to an overestimation of systolic and diastolic pressures of about 10 millimeters of mercury. Correspondingly, raising the arm above the heart level leads to an underestimation of blood pressure. Before having his blood pressure taken, the patient should remain lying or sitting for 3 minutes or standing for 1 minute. The mercury column should be vertical at eye level and not more than 3 feet from the observer. The systolic blood pressure should first be estimated by palpation. Palpate the brachial artery pulse and inflate the cuff until the pulsation disappears, then deflate the cuff. The point of disappearance represents the approximate systolic blood pressure. This avoids underestimation of systolic blood pressure when there is an auscultatory gap. The stethoscope is placed gently over the artery at the point of maximal pulsation. It must not be pressed too firmly or touch the cuff, or the diastolic pressure may be underestimated. The pressure is then raised by inflating the bladder to 30 millimeters of mercury above the systolic blood pressure as estimated by palpation. Next, the pressure is reduced at 2 to 3 millimeters of mercury per second. The point at which repetitive clear tapping sounds first appear for at least 2 consecutive beats gives the systolic blood pressure. You should hear this now. The point where the repetitive sounds finally disappear gives the diastolic blood pressure. You should hear this at 138 millimeters of mercury. Both measurements should be taken to the nearest 2 millimeters of mercury. This helps to avoid digit preference. If phase 4 is used, this should be clearly recorded. Where blood pressure is 140 over 90 millimeters of mercury on the first reading, it is suggested that a second reading be taken. At least 1 minute should elapse between readings. Blood pressure should be measured in both arms at the initial assessment, particularly if blood pressure appears to be raised. Recording should be made in both arms at subsequent visits if the pressures differ consistently by greater than 20 over 10 millimeters of mercury, or if there's a reason to suspect occlusive disease of the major vessels, or an anatomical abnormality, for example coarctation. Blood pressure should also be measured in the standing position in patients whose symptoms or drug regimes may be associated with a disproportionate postural fall. This would include, for example, diabetic patients with autonomic neuropathy. Blood pressure measurement is one of the most commonly performed procedures in clinical practice. Incorrect technique will result in false readings which may lead to unnecessary or inappropriate treatment and follow-up. This video is attempted to demonstrate the accurate technique for blood pressure measurement, which should help avoid these problems. We hope you find it useful.